You walk into the doctor's office for a simple checkup. Nothing's wrong. You just want to make sure everything's fine. 15 minutes later, you're handed a bill for $400. What happened? Well, somewhere between the waiting room and the exam table, you triggered a billing trap you didn't even know existed. And that's just the beginning. From secret facility fees to tests you never asked for to one specific word that can double your bill instantly, this is everything the healthcare system doesn't want you to know. But first, let's start with the exact moment you walk through those doors. The moment you step into a doctor's office, you're not just a patient, you're a customer, and the billing starts before you even see anyone in a white coat. It begins with that clipboard. You know the one. The form they hand you at check-in with all those questions about your medical history. Seems harmless, right? It's not. That clipboard is a billing trigger. Every box you check, every symptom you mention, every condition you list becomes ammunition for your bill later. Because here's the thing, doctors don't just treat you, they document you, and every piece of documentation can be coded into a charge. But here's where it gets really sneaky. Let's say you're going in for a routine checkup. You're healthy, nothing's wrong. You just want someone to tell you everything looks good. Simple, right? Well, there are two types of visits that sound identical but cost wildly different amounts. A wellness visit and a physical exam. A wellness visit is preventive care. Under most insurance plans, it's completely free. Zero copay, zero deductible. It's covered because the government wants people to catch problems early. Makes sense. A physical exam, on the other hand, is a diagnostic visit. That means your insurance treats it like you came in with a problem. And diagnostic visits? Those come with copays, deductibles, and surprise bills. The crazy part? The actual appointment can be exactly the same. Same doctor, same room, same blood pressure cuff, same 15 minutes of small talk while they press on your stomach. But if the paperwork says physical exam instead of wellness visit, you're suddenly paying out of pocket. So how does a free wellness visit turn into a $300 physical exam? One word. By the way. Let me explain. You walk into your wellness visit. Everything's going great. The doctor checks your vitals, asks about your diet, maybe lectures you about drinking more water. But then you remember something. That weird pain in your shoulder, that headache you've been having, that mole that looks a little different. So you say, by the way, I've been meaning to ask about this. And just like that, your free wellness visit becomes a diagnostic appointment. Because you mentioned a symptom, the doctor is now legally required to document that symptom and address it. And addressing a symptom means billing for it. This is what's called the conversion trap. And it happens constantly. Studies suggest that up to 50% of wellness visits get converted to diagnostic visits because patients mention something extra. The doctors aren't trying to scam you. They're just following the rules. But the rules are designed to maximize billing. So what's the move? If you have a concern, schedule a separate appointment for it. Keep your wellness visit clean. Don't mention symptoms. Don't ask about that weird thing on your arm. Save it for another day. It sounds ridiculous, but that's the game. Now let's talk about facility fees. This one is absolutely wild. Let's say you go see a doctor at an independent practice. Small office. Maybe it's just the doctor and a receptionist. You have your appointment, you get your bill, done. But let's say that exact same doctor works at a hospital-owned clinic. Same doctor, same appointment, same everything. Except now you get two bills. One bill is for the doctor's services. That's the professional fee. The other bill is for being in the building. That's the facility fee. You're literally being charged rent for standing in an exam room for 15 minutes. And this isn't a small charge. Facility fees can add anywhere from $100 to $500 to your visit for the same exact care. The only difference is who owns the building. Here's the kicker. Over the past decade, hospitals have been buying up independent practices like crazy. More than 70% of physicians now work for hospitals or corporate entities instead of running their own practices. So that small clinic down the street, there's a good chance it got bought out. And suddenly, every patient who walks through that door is paying facility fees they never paid before. Most people have no idea this is happening. One survey found that 80% of patients don't know what facility fees are. They just see the bill and assume that's what healthcare costs. But wait, it gets better. Some hospital-owned clinics don't even look like hospitals. They look like regular doctors' offices. Same furniture, same parking lot, same everything. But because they're technically owned by a hospital, they can charge facility fees. It's like getting charged a resort fee at a Holiday Inn. And then there's the 15-minute problem. The average doctor's visit in America lasts 15.7 minutes. That's it, from the moment the doctor walks in to the moment they walk out. Less time than an episode of a sitcom. And in those 15 minutes, they need to review your chart, ask about your symptoms, do a physical examination, explain their findings, answer your questions, and document everything for billing purposes. Why so short? Because doctors are incentivized to see more patients, not spend more time with each one. Most physicians are under pressure to see 20 to 30 patients per day. Some see even more. The math just doesn't work for long, thoughtful appointments. This creates a weird dynamic. Patients feel rushed, doctors feel rushed, important things get missed, and everyone leaves frustrated. But the billing system doesn't care. The billing system just wants volume. So you've got conversion traps turning free visits into paid ones, facility fees charging you rent for exam rooms, and assembly line medicine squeezing appointments into 15-minute slots. And this is just the check-in process. This is just what happens before anything medical actually occurs. Because the real billing nightmare starts when they order tests. That's when a simple checkup turns into a financial minefield. And the traps are way more sophisticated than anything we've seen so far. So you went in for a cough, maybe a sore throat, something simple. The doctor listens to your chest, looks in your ears, and says those magic words. Let's run some tests, just to be safe. Sounds reasonable, right? Better safe than sorry. Except here's the thing. That phrase, just to be safe, is one of the most expensive sentences in American healthcare. Because a huge percentage of the tests doctors order aren't actually medically necessary. They're ordered to protect the doctor, not you. This is called defensive medicine. And it's everywhere. Here's how it works. Doctors are terrified of getting sued. Medical malpractice lawsuits can end careers. So when a patient comes in with a headache, the doctor has two options. Option 1, use their medical training to determine it's probably just dehydration or stress, prescribe some ibuprofen, and send you home. Option 2, order a CT scan of your brain just to be safe. Option 1 is usually the right medical call, but Option 2 protects them from lawsuits. Because if that headache turns out to be something serious months later, the doctor can point to the scan and say, "See, I checked everything. I did my due diligence." Studies estimate that 20 to 30% of all medical tests performed in America are unnecessary. That's not a small number. We're talking about billions of dollars in tests that provide no medical benefit. Tests ordered purely because the system incentivizes over-testing, and you're the one paying for it. But even when a test is necessary, the billing nightmare is just getting started. Because here's something most people don't realize. When your doctor orders blood work, they don't do the actual testing. They send your blood to a lab. And you don't get to pick which lab. Your blood could go to a lab down the street. Or it could go to a lab 3 states away. It could go to an in-network lab where your insurance covers most of the cost. Or it could go to an out-of-network lab where you're suddenly paying 5 times as much for the exact same test. This is lab roulette. And patients lose constantly. The price variation is absolutely insane. A basic metabolic panel, which is one of the most common blood tests, can cost anywhere from $10 to $400, depending on where it's processed. Same test, same blood, same results, but the price swings by 4,000% based on which lab happens to receive your vial. It's like if a Big Mac cost $5 at one McDonald's and $200 at the McDonald's across the street. You'd think something was broken, but in healthcare, this is just Tuesday. And it gets even shadier when we talk about imaging. X-rays, MRIs, CT scans, the stuff that actually shows what's happening inside your body. Let's say your doctor thinks you need an MRI for your back pain. They give you a referral to an imaging center. Seems straightforward. But here's a question worth asking. Does your doctor own that imaging center? Because in many cases they do. Or they have a financial stake in it, which means every patient they send to that center puts money directly in their pocket. Now, there's a law called the Stark Law that's supposed to prevent this. It says doctors can't refer patients to facilities where they have a financial interest. Sounds good on paper. Except the law has more loopholes than a knitting store. Doctors can own imaging centers as long as they're structured a certain way. They can refer to facilities owned by their medical group. They can have all sorts of financial arrangements that technically comply with the law while completely violating its spirit. One study found that doctors who own imaging equipment order 2 to 8 times more scans than doctors who don't. Shocking coincidence, right? It turns out that when you make money every time you order a test, you suddenly find a lot more reasons to order tests. And then there's upcoding. This is where it gets really creative. Upcoding is when a medical provider bills for a more expensive service than what was actually provided. It's technically fraud, but it's also incredibly common and almost impossible to catch. Here's an example. Medical visits are billed using codes that correspond to complexity. A Level 1 visit is simple. 5 minutes, straightforward issue, minimal documentation. A Level 5 visit is complex. Extended time, multiple problems, comprehensive examination. Level 1 might bill at $50. Level 5 might bill at $250. Same doctor, same office, but vastly different charges. Now imagine you go in for a quick visit. The doctor spends 10 minutes with you, addresses one concern, and sends you on your way. That's clearly a Level 2, maybe Level 3 visit. But when the billing department processes your chart, they see an opportunity. They code it as a Level 4, maybe Level 5. Did the doctor spend 40 minutes with you discussing multiple complex conditions? No. But the billing code says they did. And unless you request an itemized bill and know exactly what those codes mean, you'll never know the difference. Studies suggest that upcoding costs the healthcare system billions of dollars annually. Medicare alone loses an estimated $11 billion per year to improper billing codes. And private insurance isn't any better. The average American overpays somewhere between $200 and $400 per year just on lab tests and improperly coded visits. That's money pulled directly from your wallet through a system designed to be so confusing that you never question it. So let's recap what happens when you get tests. Your doctor orders them for defensive reasons as much as medical ones. Your samples get sent to labs you didn't choose at prices you can't predict. The imaging centers might be owned by the people referring you, and the whole visit gets coded at whatever level generates the most revenue. That's a lot of traps for a routine checkup, but here's the dark truth. Everything we've talked about so far is outpatient care. Doctors' offices, clinics, labs, the bills are annoying, but they're usually survivable. The real financial destruction happens when you end up in a hospital. That's when the billing system stops being frustrating and starts being life-ruining. And the traps waiting for you there make everything else look like a warm-up. You go to the emergency room, chest pain, trouble breathing, something serious enough that you don't have time to shop around for the best price. You go to the nearest hospital. And here's the thing, you did your homework. This hospital is in your insurance network. You checked, you're covered. So you get treated, they run tests. Maybe you need surgery. An anesthesiologist puts you under. A radiologist reads your scans. A specialist consults on your case. Everything goes fine. You go home to recover. Then the bills start arriving. The hospital bill? Covered. You're in network. But then you get a separate bill from the anesthesiologist. Out of network. $8,000. Then a bill from the radiologist. Out of network. $3,500. Then a bill from some specialist you don't even remember meeting. Out of network. $2,200. Welcome to surprise billing. The practice of getting blindsided by out-of-network charges at an in-network facility. Here's how it works. Hospitals are complicated places. They employ some doctors directly, but they also contract with independent physicians who work inside the hospital but aren't technically hospital employees. These independent doctors can be on completely different insurance networks than the hospital itself. So you walk into an in-network hospital and you assume everyone who treats you is also in-network. Reasonable assumption, right? Wrong. The anesthesiologist might be out of network. The radiologist reading your scans might be out of network. The ER physician might be out of network. And you have zero control over who treats you when you're unconscious on an operating table. For years, this was completely legal. Patients would get hit with surprise bills, totaling tens of thousands of dollars for decisions they never made. In 2022, Congress passed the No Surprises Act to address this. And it helped. The law protects patients from many surprise bills in emergency situations. But the law has gaps. Massive ones. Ground ambulances aren't covered. Some post-stabilization care isn't covered, and the enforcement mechanisms are still being figured out. Surprise billing is less common than it was, but it hasn't gone away. Patients still get caught, and that's just one hospital trap. There's another one that's even more insidious. The observation status scam. Let's say you go to the hospital and they keep you overnight. You're in a hospital bed. You're wearing a hospital gown. Nurses are checking on you. Doctors are monitoring your condition. You're clearly admitted to the hospital, except maybe you're not. Hospitals have two classifications for patients staying overnight: admitted and observation. If you're admitted, you're an inpatient. Your insurance covers you like a regular hospital stay. But if you're under observation, you're technically an outpatient, even if you're in a hospital bed for 3 days. Why does this matter? Because the billing is completely different. Under Medicare, inpatient stays are covered under Part A. Observation stays are covered under Part B. Part B has higher copays. But here's the really nasty part. If you need nursing home care or rehabilitation after your hospital stay, Medicare only covers it if you were an inpatient for at least 3 consecutive days. Observation days don't count, so a senior citizen goes to the hospital, spends 4 days in observation status, thinking they're admitted, then gets discharged to a nursing home. And Medicare says, sorry, you weren't technically admitted, so we're not covering your rehab. That nursing home bill, all on you. We're talking $10,000 to $20,000 or more. Hospitals do this constantly. It's safer for them. Less regulatory scrutiny, less risk of audits. The patient absorbs the financial consequences. And then there's balance billing. This is the practice of billing patients for the difference between what a provider charges and what insurance pays. Let's say you have a procedure. The hospital charges $50,000. Your insurance company says that's ridiculous. We think this procedure is worth $30,000, so that's what we'll pay. In a normal world, the hospital would accept $30,000 and move on. But in balance billing, the hospital comes to you for the remaining $20,000. You didn't agree to pay $50,000. You had insurance. You thought you were covered. But now you're on the hook for the gap between reality and whatever fantasy number the hospital put on their price list. And where do hospitals get these fantasy numbers? From something called the Charge Master. The Charge Master is a hospital's internal price list. Every hospital has one, and they're completely made up. There's no logic, no connection to actual costs, no standardization between hospitals. One hospital might charge $15 for an aspirin, another might charge $50. Same aspirin, same pill, wildly different prices. The Charge Master is how you end up with viral stories like being charged $40 to hold your own baby after delivery. Skin-to-skin contact, they called it. $40. Or being charged $500 for a nurse to hand you a box of tissues. Or getting a whopping $200 bill for an ice pack. These prices are negotiating positions, not real numbers. Hospitals set them astronomically high so they can negotiate down with insurance companies and still make a profit. But if you don't have insurance, or if balance billing kicks in, you're getting billed the Charge Master rate. The fake price. The price designed to be negotiated down that no one is ever supposed to actually pay. This whole system adds up to a crisis. Medical debt is the #1 cause of bankruptcy in America. More than credit cards, more than mortgages, more than any other factor. An estimated 100 million Americans currently have medical debt, and the collections process is brutal. Unpaid hospital bills typically get sent to collections within 60 to 180 days. Once it hits your credit report, your score can drop by 100 points or more. That affects your ability to rent an apartment, buy a car, get a mortgage, even get certain jobs. People lose their homes over hospital bills. They drain their retirement savings. They go without food and medication to make payments. And often, these debts started with a single unexpected medical event at a hospital that was supposed to be in network. That's the system. Surprise bills from doctors you didn't choose. Observation status that strips your coverage. Balance billing for fantasy prices. And collections agencies waiting to destroy your credit the moment you fall behind. But here's the thing. You're not completely powerless. There are ways to fight back, questions you can ask, laws that protect you, tactics that actually work, and the hospital billing departments really don't want you to know about them. Okay, so the system is rigged, but here's the good news. You can fight back, and it starts with 3 words that make hospital billing departments very nervous. Itemized bill, please. When you get a medical bill, what you're usually looking at is a summary. Total amount due. Maybe a few line items. But not the real breakdown. The real breakdown shows every single charge, every aspirin, every bandage, every minute a nurse spent in your room. And when patients actually request itemized bills, something magical happens. Errors appear everywhere. Studies suggest that up to 80% of itemized medical bills contain errors. 80%. Charges for procedures that never happened. Duplicate billing for the same service. Medications you never received. Rooms you were never in. The billing system is so bloated and automated that mistakes are basically guaranteed. Hospitals know this. They're counting on you to just pay the summary without questioning it. But when you request an itemized bill, they have to justify every charge. And suddenly, that $12,000 bill might become $8,000. That's not negotiation. That's just correcting their errors. Here's exactly what to say. I'd like a fully itemized bill with CPT codes for every charge. CPT codes are the standardized billing codes that describe each procedure. Having those codes lets you look up what each charge actually means and compare it to standard rates. Knowledge is leverage. And speaking of leverage, hospitals expect you to negotiate. Most people don't realize this, but medical bills are not fixed prices. They're opening offers. Hospitals have entire departments dedicated to working out payment plans and reductions. They'd rather get something than nothing. So here's your script. Call the billing department and say, I've reviewed my itemized bill and I'd like to discuss a reduction or payment plan. I'm unable to pay this amount in full. Then stop talking. Let them respond. Most hospitals will immediately offer a discount, 10%, 20%, sometimes more. They might offer a payment plan with 0 interest. They might point you toward financial assistance programs you didn't know existed. The key is asking. Most people never ask. If they push back, mention that you're aware of their financial assistance policies. Under federal law, nonprofit hospitals are required to have financial assistance programs. And most hospitals, even for-profit ones, have charity care policies that can reduce or eliminate bills for qualifying patients. You might qualify. You don't know until you ask. But the best way to avoid surprise bills is to ask questions before anything happens. Before any non-emergency procedure, you have the right to know what it will cost. Here are the questions to ask. First, is this provider in my insurance network? Get confirmation in writing if possible. Ask about every provider who might be involved, not just the main doctor. Second, what is the CPT code for this procedure? Once you have the code, you can call your insurance company and ask exactly what they'll cover. You can also use online tools to compare prices at different facilities. Third, is there a facility fee? Remember, hospital-owned clinics charge these. Ask up front so you're not blindsided later. Fourth, can I get a good faith estimate? Under a law that took effect in 2022, healthcare providers are required to give uninsured patients and those paying out of pocket a written estimate of expected charges before non-emergency services. If the final bill exceeds the estimate by more than $400, you can dispute it. This law doesn't apply to everyone in every situation. Insurance complicates things. But it's a powerful tool when it does apply. And even if you're insured, asking for an estimate puts providers on notice that you're paying attention. State laws matter too. Some states have banned balance billing entirely. Some have surprise billing protections that go beyond federal law. Some require hospitals to provide price transparency. The rules vary wildly depending on where you live. It's worth spending 10 minutes looking up your state's healthcare consumer protections. And here's a weird one. Sometimes paying cash is cheaper than using insurance. I know that sounds backwards. You pay premiums every month specifically so your insurance covers medical costs. But here's what happens. When you use insurance, the provider bills your insurance company an inflated rate. Your insurance negotiates it down, but your copay or coinsurance might be calculated based on the inflated rate. And if you haven't hit your deductible, you're paying the negotiated rate out of pocket. Meanwhile, many providers offer a cash price for patients paying directly. No insurance middleman, no billing department overhead, just a straight transaction. And sometimes, especially for common procedures and lab work, the cash price is lower than what you'd pay. Through insurance, it's worth asking, what's your cash price for this? You might be surprised. Now let's talk about where all this money goes. The average American spends about $2,500 per year on healthcare. That includes insurance premiums, out-of-pocket costs, and taxes that fund government healthcare programs. Per person. Per year. The United States spends roughly twice as much per capita on healthcare as other developed nations. Canada, Germany, France, the UK all spend about half what we spend, and their health outcomes are often better than ours. Where does the money go? About 25% of all U.S. healthcare spending is administrative costs. Billing departments, insurance paperwork, prior authorizations, coding specialists. We have an entire industry dedicated not to providing healthcare, but to processing the payments for healthcare. 100 million Americans have medical debt. Medical debt is the #1 cause of bankruptcy. The average emergency room visit costs $2,200. A hospital stay averages $11,700. An MRI can range from $400 to $3,500 for the exact same scan at facilities in the same city. The system wants you confused. The system wants you to feel powerless. The system wants you to just pay whatever bill lands in your mailbox without asking why. Don't. Request itemized bills. Negotiate every charge. Ask questions before procedures. Know your rights. Compare cash prices. Look up your state's laws. And when the billing department tries to steamroll you, remember that they're expecting you to give up. Most people do. You don't have to be most people. And if you think doctor visits in hospitals are bad, wait until you see how prescription drug prices work. That's a whole other level of insanity. But that's a story for another day.